dear colleagues, we have to start with the poster session. Luis Montalva and I, Radovica Jokic, we will be chairman in this session, and we will start with endoscopic technology for blue rubber black nail syndrome, a delayed diagnosis. Giulia Franci and four other authors from Milan. Yes.
Good afternoon.
We present the case of a 15-year-old female presenting to our department with the history of iron deficiency anemia refractory to therapy. At birth, she had been submitted to a partial removal of venous malformation in the paravertebral left region. Before coming to our department, she had already been submitted to various unsuccessful evaluation, and in considering the physical examination and the clinical history of these patients, a congenital vascular syndrome was suspected. She was then candidated for the execution of a video capsule endoscopy. The video capsule endoscopy was performed and revealed the presence of tenangioma with pathognomonic clinical appearance. The diagnosis of blue rubber nevus syndrome was established based on our experience. Video capsule endoscopy should be considered as a promising screening modality for the diagnosis of suspected gastrointestinal vascular malformation or chronic anemia in children. It provides a kind of map of any vascular lesion that affect the internal viscera. Thank you.
Thank you very much. Very, very interesting case. I hope that the discussion from the audience will be also interesting.
Thank you.
First of all, who found the same illness in the audience? Because it's really very, very rare.
Rare. There are 100 cases in literature.
That's the reason, because nobody still asks about that. I didn't find only the therapy, everything about diagnosis. I understood that therapy.
The therapy is based in the personalized on the patients and can be through steroidization or sclerotherapy. In these patients, we decided to administer steroids. And between a year, we repeated the video capsule endoscopy to evaluate the efficacy of the therapy.
Okay.
Thank you very much.
So for the next communication, we're going to call Javier Arnoldo Montero. He has 5 presentations in a row. So maybe if you're coming back, you can present all of them, and then we'll have the questions at the end.
To encourage your fast presentation with 5 posters, we will suggest some kind of awards for you and your group.
Thank you very much.
We hope you have a lot of questions.
Well, all these works are directed to identify new biomarkers in the context of pediatric acute appendicitis for diagnosing and also for discriminating between complicated and non-complicated pediatric acute appendicitis. This first one is a meta-analysis and a systematic review we performed regarding hyperprotectin. We found 10 articles of prospective performed in a pediatric population with nearly 4,000 participants. We identified papers which studied serum, urinary, and fecal calprotectin, and also AG1, which is equation which includes calprotectin, C-reactive protein, and the white blood count. We didn't found high-risk biases in these studies. And what we found, is that calprotectin shows a very wide range as a molecule, so its performance in pediatric acute appendicitis is quite limited. But the AP1 is a test that reliable can exclude the diagnosis of pediatric acute appendicitis. So what we conclude is that the AP1 is a useful resource in order to exclude the diagnosis of pediatric acute appendicitis.
Okay. The next one. Next presentation, please. Next poster, please.
These are prospective works in which we evaluated different molecules, also in the context of pediatric acute appendicitis. Okay, this is a prospective validation study which was performed in patients aged 2 to 14 years. This complete analysis, I don't know what it's spelled, sorry, included 95 patients. There were not statistically significant difference in the socio-demographic variables. I don't know what it's spelled, sorry. On the analytical variables, we found difference in the fever, in the leukocytes, neutrophils, CRP, and the PCT. And regarding the interleukin 6, we find a significant statistical difference between the uncomplicated and complicated pediatric acute appendicitis. Regarding the diagnostic performance, we found an R-handed curve of 0.77 and a sensitivity and a specificity associated of 84% and 65%. What we conclude is that this is a tool which has a moderate diagnostic performance when discriminating pediatric acute appendicitis, complicated and non-complicated, and it could be implemented in future tools in order to decide which patients are suitable for surgery or for conservative management.
Thank you. Next presentation, please.
This study
They're jealous. They're jealous.
Yeah.
Can you press pause on your...
No, I'm not present. I don't know why it's.
Maybe you press pause.
Like you have a pause button.
It does have 5 minutes.
Next presentation.
This presentation is regarding pentraxin-3, which is an inflammatory molecule which has been widely assessed in the last years in different contexts. This molecule belongs to the family of the long pentraxins, just as the C-reactive protein, and what we evaluated was the diagnostic performance of this molecule in pediatric acute appendicitis. What we saw also in the same study, the same cohort, is that there were significantly different levels in the pentraxin levels in the group of controls and in the pediatric acute appendicitis groups. And regarding the diagnostic performance, we show a lower value of 0.77 with an associated sensitivity and specificity of 61% and 73%. In this case, what we conclude is that this is not a sufficient tool in order to diagnose pediatric acute appendicitis, and although in the previous literature it has been published that the R&D curve was nearly 95%, we didn't find that, so we don't rely on that. Thank you.
Next presentation.
these two last works, I think, which have more clinical impact and probably are more relevant for this congress. In this case, we evaluated the prevalence of the coagulopathy in the non-complicated and complicated periodic acute appendicitis subgroups of our cohort. We didn't find a very abundant literature regarding this matter. What we found is just 2 articles in which they evaluated the coagulopathy in these patients, and we wonder how frequent it was in these patients. What we found is statistically significant difference in the INR values and in the fibrinogen values in the both groups. And we also find difference in the prevalence of alterations in these 2 markers between the complicated and non-complicated PAA. It was surprising that we had a prevalence of alterations in these markers as high as 78%, which is quite high. Comparing with adult series in which they have nearly 5-10%, I think this is a thing that warrants further studies and probably needs to be widely assessed. Thank you.
The next presentation, please.
Okay. And in this last work, what we evaluated is a panel of biomarkers, as we have done in the immediate postoperative period of pediatric acute appendicitis. Our main hypothesis was that there could be a correlation between these values and the clinical variables, such as the admission time or the onset of tolerance. As I have mentioned previously, in the preoperative values, which we were obtaining in the emergency department, we saw significant, statistically significant difference in the pentraxin 3 and in the IL-6 values, but also 12 hours after the surgery, we found statistically significant difference between the complicated and non-complicated pediatric appendicitis in postoperative IL-6 values. When we executed some correlation analysis, we found that there was a moderate correlation between the admission IL-6 values and the postsurgical values. We found the same for the NGAL, not for the pentraxin, but probably the most interesting finding was that there was a moderate to high correlation between the postsurgical IL-6 values and the days of admission of the patients. I have not taken it here, but we found a nearly similar correlation to the onset of tolerance. So we think this may be an interesting avenue to have a biomarker which can correlate with the admission time and the onset of tolerance in this kind of process, and probably not just in appendicitis, but in other surgeries in pediatric patients. Thank you.
Thank you very much.
When you decide to operate the patients, what is your rate of normal appendix? When you decide to operate the patient for acute appendicitis, complicated, non-complicated, what the rate of normal appendix you have?
Of wide appendectomy, you mean?
No. What is the rate of normal appendix after all this?
Of normal.
Yeah.
Now, in this cohort, we didn't have a normal appendectomy. All they had histopathological inflammation, and all they were considered at least phlemonous appendix.
Okay. Second question: when you operate the patients, tell me that you're doing laparoscopy.
All of these patients were operated by a minimally invasive surgery. 95 to 96% were operated by a single port, and 2 to 3%, depending on the group, were by 3 ports.
In other papers, he made the operation. Thank you very, very much.
So the next speaker will be Louise Murchison, and will be talking about robotic-assisted lymph node dissection in child.
Thank you for the opportunity to present. So robot-assisted retroperitoneal lymph node dissection isn't a new procedure. It's been performed in adults as early as 2006. However, the number of cases performed in children is in single isolated case reports. In our centre, we performed a case in a 14-year-old boy. This is a 14-year-old boy who had a history of a mixed germ cell tumour of the left testis, and he had undergone 3 cycles of chemotherapy and also had negative tumour markers. However, on his follow-up, when he came to having a CT scan, we found that there was a persistently enlarged 3 centimetre left para-aortic lymph node. So this was then taken to our multidisciplinary team meeting, and after that discussion, it was decided to proceed with robotic-assisted retroperitoneal lymph node dissection. So in performing this case, we used the Da Vinci Xi robot, and the patient was positioned in a steep chest belt in a Kundelberg position. We used 5 ports, and then we mobilised the cecum and iron using personal dissection, and then that exposed the inferior vena cava and the aorta. And then we subsequently performed dissection of all of the lymph nodes. And we obtained negative margins on those lymph nodes, and we also have minimal blood loss of 100 millilitres, and the operation itself took 210 minutes. And the patient went home 2 days post-operatively with no complications. So in this study, this case report, we've shown that it is possible to do this procedure in a paediatric population. However, because there's so few cases, we would need to do some further work to work out if there was enough evidence to support whether this should be done robotically or whether it should be done laparoscopically. So similar theme to lots of other proposals that have been discussed today. Thank you.
Very much for this presentation. Any questions from the floor? Any comments?
Let's do something about therapy after histological confirmation of teratoma in combination with previous.
So he had completed 3 cycles of DTE chemotherapy, and then initially started first with an oncology, then chemotherapy, and then our routine practices that we perform CT in all of those patients, and then take them to a multidisciplinary meeting, and after those patients discuss to decide further management of patients.
Thank you very much.
So the next speaker will be Cosimo Glev for minimally invasive surgery and 3D reconstruction in treatment of challenging giant cystic lymphangioma, advantages of techniques. Do we have Cosimo here? Okay, if he's not there, we'll do the next one, should be laparoscopic management of tubal torsion in pediatric age, experience from a single center, presented by Margarita Rivera.
I present the experience of our center in treatment of tubal torsion. Tubal torsion is a very rare condition in women and even more in pediatrics. And between November 20 and May 2022, 4 patients came to our attention with tubal torsion. All patients presented abdominal pain and specific symptoms. The US was not conclusive and showed abdominal mass. 3 patients underwent MRI that showed tubal torsion and annexal system. In 3 patients, our approach was laparoscopic, and we preserved the annexa after the location and cystectomy. Unfortunately, in the last patient, the presence of a huge annexal mass involving also the ovary needed conversion and open ovarectomy. Laparoscopic approach confirms to be the best choice for both the diagnosis and management of annexal pathologies, and this is moreover important considering how important it is to preserve the annexa for the normal growth and future fertility.
marker too, and they can bring your attention and then they do the torsion.
Yeah.
And what was your cure, your treatment? Because it's going to retorsion again, and finally the others said that the gynecologist prepared to take it out because it's not going to be a haircut later. I have one that she do a torsion again, and finally the others, the gynecologist prepared to return this ovarian fallout. You have?
I'm not sure I understood clearly.
You can have like a fluid retention in your
okay.
fallopian tube, because of an obstruction, which is congenital.
No, we didn't have. There was always there was an nasal cyst in the torsion, causing the torsion.
It depends on the size of the cyst. Because I have a series of this one when it present. If the cyst inside the tube, it is the retention cyst. The cyst below the tube is a tube in the bone ligament system, so you can excise only the cyst.
Yeah.
And by after excision of the cyst only, you can review if the tube is intact or not.
Yeah.
So retention cyst is inside the fallopian tube. This you may think to take the tube off. But I will not take it from the first time. I will excite the cyst in the first chance. I will not take the tube from the first time. No.
And my question is, in all patients, preoperative tumor markers were normal.
Yes.
Were normal. Only one with elevated.
Yes, but according to our opinion, that patient was the one with more symptoms like fever, intestinal obstruction, and it was caused by the inflammation.
Thank you very much.
Okay, the next one will be ovarian cyst torsion and asymptomatic Morgani-Halia, and 12 years old with Ehlers-Danlos. Case report presented by Joshua.
Good afternoon, I'm Joshua from Indonesia. About the case, a girl with intermittent pain 3 months prior admitted to ER with a mass in the lower abdomen. Its size was 10 times 10 times 5 cm. This patient also has Ehlers-Danlos syndrome symptom, which she got repeated pathological dislocation on both of her legs when she had certain activity with a 5 scale based on the Becton scale and frequent bruising and on her body. Skin hyperextensibility was present. She had no familiar history with EDS, but we didn't perform scan biopsy and chromosome analysis due to limited resources. She also had compensated Morgani hernia. Prior to her presence in ER, we had assessed the patient with ovarian cyst, thoracic scoliosis, and Morgani hernia based on the abdominal CT. Nonetheless, her parent refused to laparoscopic cystectomy as her condition improved clinically at the time and concerned about the EDS. 2 weeks after her diagnosis, she admitted to our ER with acute abdominal pain. Hence, we performed a laparoscopic procedure. Rectal ovarectomy was performed due to necrotic ovarium and coughing. Currently, this patient had no complaints and recovered eventually. Conclusion: EDS, also the procedure must be as minimalist as possible. Thank you.
Any questions from the floor?
Or suggestion maybe about organic hernia?
I have a question. Why did you choose to treat conservatively for Morgani hernia? Why did you not close it?
Because there is no symptom, and we're afraid if we do repair the hernia, it can disturb the physiological things that he already adapted with the condition and situation for the Morgani hernia.
But in the future, will you do that? Or
yeah, we hope that there will be no symptom or anything in the future.
And just the last question, if this patient becomes pregnant, what about increased pressure in her abdomen and the hernia? What will you tell her?
We think it later. Okay. Thank you very much.
Okay, the next one is Nicotic always non-viable? Analysis of ovarian torsion in a single institution retrospective study by Anita Piotrowska-Gao.
Ladies and gentlemen, guidelines are clear. We need to preserve ovaries after ovarian torsion. But have you ever wondered what is happening to them after the torsion? So we collected data on demographics, on labor symptoms, intraoperative diagnosis, and we analyzed the ultrasound exam which were performed postoperatively. In our study, on our 44 patients, the data showed that 85% of our patients had viable follicles on postoperative ultrasound exams. Thank you.
The question and comment from the audience, please.
Thank you very much for that information. Did you have any correlation to the color you saw during the operation? Is there anything where you say
different?
Yes, we divided our intraoperative descriptions into 3 parts, like the ones that were fully recovered, the other ones that were partially recovered, and the ones that were described as necrotic. So that we included in our study. And in necrotic ovaries, there were only 2 ovaries that were homogeneous and they didn't have any follicles. And in ovaries that were described as partially recovered, there were 2 cases.
Thank you very much. Any other questions? No? Then we go on to the next presentation. Thank you. Next one is minimally invasive management of ovarian masses in adolescents. Report of 3 cases by Gordon Sepp.
We had 3 adolescent patients that we decided to operate laparoscopically with ovarian masses, and the decision was taken after exploring the peritoneal cavity and assessing the lack of problems with nose and assessing the dimensions and the physical appearance of the masses of the ovaries to make sparing surgery by minimally invasive procedure. So this is what we did with these 3 patients, and the results in abdominal pathology were mature cystic ovarian tetroma in 1 case and borderline cyclosporidias
Leyla.
Good evening, everyone. I'll be presenting today a safe technique that we have been using in single incision laparoscopic ovarian cystectomy to avoid spillage of the cyst content into the peritoneal cavity. So our technique is to start with transumbilical incision, then insertion of the cell spore. After insufflation and identification of the ovarian cyst, an additional 15 mm trocar is placed in the contralateral lumbar region, and an endobac is inserted and placed underneath the ovary and the cyst. You can see here in the image both laparoscopic instruments along with the ovary and the cyst all inside the endobac, and the dissection is completely done inside the endobac to prevent any spillage of the cyst content to the peritoneal cavity. After complete dissection, the cyst is retrieved completely outside the abdominal cavity inside the endobac. Our result for the cyst ranging between 5.6 to 12.5 centimeter. We had no reported endobac rupture. There was only 2 cysts that ruptured inside the endobac with no intraperitoneal spillage. All has an excellent cosmetic result. As you can see, the umbilicus scar is very cosmetic, and there was no recurrence in all the follow-up. To conclude, single incision laparoscopic ovarian cystectomy with manipulation and dissection of the cyst inside the endobac is feasible and safe, and for the cysts that are less than 14 centimeters, and have a good cosmetic outcome. Thank you.
Comments or questions from the audience, please? Is it necessary that additional incision for the back when you have cells?
Yes.
This was the stage of the tumor. It's priority. The stage of the tumor or the excess scar that
This because you have a protocol for any oncology, because you don't know it's been most of the are benign cytoplasmic disease, but you don't know before, so I'm not taking any risk for tumor spillage in the abdomen. So I'm putting the bag in the opposite side of the ovarian cyst from the 15 bag, discovered in the left, and all the surgery is cells. So just put all the bag, all the cysts inside the bag, do all the surgery inside the bag, wash the ovary inside the bag, and start. And put the ovary outside, close your bag, and leave the tumor outside. Now the tumor will be taken from the cell support umbilic, because you can extend the umbilic and you can put it back as normal.
Why you can't put the bag through the one of the working port in the cells?
No, you can't. The cells is
5 millimeters, 5 millimeters.
No, the tumor is 15 centimeters. The ones has to use the 15 millimeter bag. We have no choice. And the smaller kit you can go for, it depends on the size of the tumor, but the 15 it needed girded above 80 years. The small gird were lucky to pose 8 centimeter with 10 centimeter bags. But I prefer to avoid spillage under any over the laparoscope. We don't have problem till now with this. And it was very old under the 3 years to be very safe. They can be inside the bag as you want. Thank you.
Thank you very much for your explanation.
The next presentation will be a brief description of a simple, safe technique to maintain and guide abdominal respiratory tract in laparoscopy oculopexy by Ines Romero.
Laparoscopy has been widely used in the management of mental diseases. In this study, we describe a very simple and safe technique to maintain and guide abdominal scrotal tract during laparoscopic oculopexy. During laparoscopic exploration, after full mobilization of the testis, a scrotal incision is made and dartus pouch is created. Then a malignant forceps is passed from the abdomen to the scrotum through the internal ring under direct laparoscopic guidance and through also by external palpation of the superficial inguinal pouch, as you can see in the first figure. Then a mosquito forceps passed from the scrotum into the abdomen, guided by a piece of feeding tube holding both forceps from either side. Once inside, the mosquito forceps dilates the tract and pulls the testis into the scrotum. Using this technique, the main advantage is to create a tract and a controlled direct vision. It avoids uncertainty of the tract and damage to the inguinal structure, and also avoids testicular torsion during pull-out. Thank you.
In bariatric surgery, they use something similar also. Thank you. Thank you very much. Some comments maybe or questions? Everything is clear and very useful.
Very cheap.
Very cheap. Thank you very much.
Next presentation will be single-stage laparoscopic arteriopexy for intraabdominal testis in children under 2 years old by Giuseppe Otorino.
Thank you for the introduction. Good afternoon, dear colleagues. This is our retrospective analysis of all our cases performed under 2 years old of a single-stage arteriopexy that was performed by dissecting the gubernaculum and performing the stretching test to value the feasibility to pull down the testicle inside the scrotum. We've had a follow-up of up to 17 years. All patients were called on a phone survey. The results are here in the panel. You can see we had a very high answer rate. We also try to ask for the patients to investigate their satisfaction with scars. And as you can see, we had a very low percentage of post-operative hypertrophy, among which one patient had an undergoing condition. So this analysis allowed us to understand that this technique is not only feasible, but also very well received among parents. Thank you very much.
Is all the cases can you do single stage?
Yes, all the cases under 2 years old were done in a single stage, all performed by the same surgeon. We only had one case that needed a two-stage orthopexy, but it was over 2 years old, so we excluded it from the cases.
We have a good few number in bubble testes. I have to say, 2 of my cases I had to do single stage, but I found it under tension, so I took it back and did it two-stage. I see just a message for the 3E. Not all the cases can be done as a single stage. Yes, I'm doing a good few number single stage, yes, but I don't think all the cases under 2 years of age can do single stage.
The thing is that with all our cases, the stretching test performed was positive, so we managed to. Maybe we were just
only with chest.
No. Is the test not to do two-stage? Is what you mean?
The testis was put down in one stage, and the feasibility of this was done by stretching the testis on the contralateral inguinal ring, and all of our cases had positive stretching tests, so we managed to put them down even after.
Are you planning on comparing to another institution's practice, maybe, with two-stage?
We are planning to compare not only for the 2 stages orthopexy, but also concerning the dissecting or sparing the gubernaculum, which could be an interesting data, especially considering the post-op hypertrophy. Thank you very much.
Thank you very much.
The next presentation is endoscopic treatment of vesico-urethral reflux in Tunisian center experience by Mariam Beji. She has presented already. Okay. So the next one will be de novo vesico-urethral reflux arteriotorsal decompression in children, a systematic review and meta-analysis comparing laser puncture versus electrosurgical incision techniques from 10B Ultra.
Good evening, everyone. So we compared the outcomes of electrosurgical decompression in a laser puncture versus the electrosurgical incision technique, and we compared the primary outcomes that we saw were whether or not there was any de novo vesico-urethral reflux which occurred in the renal unit which was punctured. And the secondary outcomes also I'll be discussing later on. So we did a systematic review, and in the end we included 4 studies which were retrospectively analyzed. In the characteristics of the study, we saw there was a clear-cut female preponderance, which is already reported in the literature. Along with that, the percentage of duplex system in the ureterocele side as well was reported in around 3 studies, and around 70 to 80% of the ectopic ureters were also reported. Coming to the primary outcomes, wherein we saw whether or not there was a de novo vesicular reflux in the renal unit, which was punctured either with the laser technique or the electrosurgical technique. The de novo VUR was reported in all the 4 studies, and out of the 202 children, around 67 developed reflux. However, the incidence was much lesser in the laser puncture group versus the electrosurgical group. And this result was also found to be statistically significant on comparative analysis, as you can see in the graph as well. So the secondary outcomes were assessed in 2 phases. The first one was whether or not we required endoscopic retreatment of the ureterocele, which meant that there was inadequate decompression in the first stage of the surgery. And this was reported in around 20 children, and again the incidence was more with the electrosurgical group. However, on statistical analysis, it was not found to be significant. The other secondary outcome which was studied was the need for anti-reflux procedures, which were either reimplantation or it was a endoscopic copolymer injection into the native ureteric orifice itself. And in this also it was found that the laser procedure was better, and it needed lesser anti-reflux procedure as compared to the electrosurgical group. Thank you so much.
Any questions or comments? What do you do in your center?
I'm a resident. Fellow at the
So, what technique do you use in your center?
Oh, I'm sorry. We use the electrosurgical technique as of now, but we are in the recruitment process to compare in a prospective manner the laser versus the electrosurgical technique.
Thank you.
Thank you so much.
The next presentation will be double J catheter removal without anesthesia, our in vivo results by Edith Kegset.
Good evening, everyone. So we analyzed all the data of our pediatric patients who had one-sided DJ catheter removal in our study period. This is not my slide. In that period by a non-cystoscopic and non-anesthetic technique. The essence of this technique is to create an open loop with a monofilament suture sewed on the end of a feeding tube. It passes through the urethra into the bladder. We twisted it around a few times, then we pull it out, and the DJ catheter is enrolled and removed by it. In our study period, we performed DJ catheter removal in 25 patients. There was no preoperative complications. The removal was successful after an average of 2.5 trials. After anterogram DJ catheter insertion, the successful rate was 100%, and after retrograde insertion, it was significantly lower. We compared our data with the cystoscopic interventions in the previous year after laparoscopic pyeloplasty. We found that the surgical time is significantly lower in the non-cystoscopic technique, and it is way more cost-effective. Our conclusion is that this is safe and effective method in the pediatric populations. It is less burdensome for the patients. It shortens the time of the interventions and the hospital length of stay, and it's cost-effective. Thank you.
Thank you very much. Could you previous part of the slide of your presentation?
We have a presentation?
Please, poster. Show us the poster.
Like the one before.
One before. You gave me a job. I had to find that way for taking out. That's very interesting. Explanation of that without cystoscopy taking out WJ stent. It's your self-made.
Yeah, it is.
Yes, that's also very important to highlight.
Thank you.
Thank you very much.
Next presentation, a tertiary center experience in varicocele management in children, presented by Dr. Dunseth.
We started treating varicocele by laparoscopy 9 years ago, and we did a retrospective study with a chart of 150 patients operated for, in fact, admitted varicocele during the last 9 years in our center. From these, we eliminated 44 cases which were not operated for admitted. So we had 60 cases operated laparoscopically, 46 laparoscopically, and we studied the data for these two series to see what is relevant for operation. So one thing that came out, it seems that the total duration was not really very different. This is also because we had started the laparoscopic techniques, we were a little bit careful and maybe kept the patient a little longer than really necessary. The total duration in the operating theater obviously was significantly higher in the laparoscopical group. The relapse we had one in the classic treated and 5 laparoscopy group, and postoperative hyperoscopy, 9 in the classical group, and 6, 10% in the laparoscopy group. So we still have to refine our method. Maybe in 10 years we'll do again another study and see how we do then. Thank you.
Some question, maybe some would like to ask you something. Or comments? Thank you very much.
We will go on to the next presentation, which is barbed versus non-barbed suture for keratoplasty via the mini-invasive approach, systematic review and meta-analysis by Gaurav Prasad.
Good evening, everyone. So the most difficult and challenging step in laparoscopic pyroplasty is the intracorporeal suturing. Barbed suture has the advantage that it avoids the need to tie knots intracorporeally. So we basically conducted a systematic review and meta-analysis comparing barbed versus non-barbed suture for pyroplasty. Eventually, 5 studies were included in the meta-analysis, and we found that the duration, operative duration, was less in the barbed group compared to the non-barbed group, and this was a statistically significant result. However, the rates of redo pyroplasty as well as the post-operative complications were higher in the barbed group, although these two results were not statistically significant. The studies that were included were mostly of observational nature, and further RCTs are needed in order to draw definitive conclusions regarding the same. This was a Prisma diagram, and eventually 5 studies were included. Thank you.
Questions, comments? Who used barbed suture for please? Nobody.
Even now, technically, they're using non-barbed only.
Yes, I know that people from Croatia, they do your papers.
And any idea what kind of complications you could have with barbed suture?
The risk of stricture, redo pyroplasty would be more
Infection.
14-year-old girl with cervical disease, presented by Jaya Kumar.
Good evening, everyone. My patient is a 14-year-old girl who presented with complaints of amenorrhea, pain and lump in the abdomen. On clinical examination, she had normal secondary sexual characteristics for her age, and there was a lump in the abdomen. And genital examination revealed a blind ending vagina. On further investigation, the patient was found to have an enlarged uterus with hematometer, bilateral hematosalpinx. The upper part of the vagina was absent along with cervical atresia, and the distal vagina was only 2 centimeters long, suggesting cervicovaginal agenesis. So we proceeded to perform a total laparoscopic colovaginoplasty. Here are the port positions. We used 2 12 mm ports and a 5 mm port. The procedure started with decompressing the uterus by aspirating the hematometer, fetching it to the anterior abdomen wall, and proceeding to the pelvic resection combined with the perineal resection. We measured the colon length required for vaginoplasty, and we pulled through the colon flap and performed new vaginal opening in the perineum. And here there is a schematic representation of the anastomosis between the colon and the uterus. We used absorbable sutures for the anastomosis. Post-operatively, the patient was continued on medications to stop the menstruation. She was allowed to have feeds on second day, and she was discharged with 7 days. 1 month after the surgery, a scoping was done to find an intact anastomosis on both the ends, while the medications to stop the menstruation were continued. The surgery was particularly challenging because the entire procedure was done laparoscopically with only just 3 ports. It was technically demanding, and it required extensive intracorporeal surgery. To conclude, laparoscopy is a valid alternative for open surgery to perform colovaginoplasty. It is technically demanding while giving a cosmetically better outcome, and for patient, the benefits include early recovery and shorter hospital stay. Thank you.
Great operation. Perfect. Comments? Question? Gynecologist help you during that operation and your team?
Our pediatric surgical team performed this surgery.
Congratulations.
Thank you very much.
And the last presentation for this session is a young pediatric surgeon from COVID era, outcomes for gaining minimal invasive surgical experience during pandemia, a single center experience, from Theodoros Dionyssos.
Hello and good afternoon. So this our question and our research is during the COVID era, because the COVID era followed in our country a very hard 10-year economic crisis, and we had to, our aim of our review was to see the outcomes from the registrar, not from the registrar. So in a period of 18 months, we reviewed 60 MIS procedures, mainly laparoscopically, ABGI, cystoscopy, and thoracoscopy. And from these 60 MIS procedures, 15 done in elective case and 15 in emergency setup. If you see an emergency setup, it's without thoracoscopy. Because our protocol in the EMAS is TPA at the class instead of AVAX. So, and if you see in the front graphic, our economic crisis in these years very heavy and became a middle income country. So we have a gap in the elective cases with versus emergency cases. The registrars lost the emergency MIS procedures ability, but they gained the elective procedure. Why this happened? Because the PCR test, unfortunately, we have to wait for 24 to 30 hours. And we cannot afford economically the quick PCRs in 2 hours period, which are very minimal in these cases. So what is the conclusion and why this gap happened? this can happen because of the economic crisis. Instead, and we have the economic crisis that ended, but what we gain from the economic crisis, we gain the elective cases MIS procedures to be performed by the registrars, and that happened because of the surgery team that had the willing to go a step ahead. Finally, according to the IMF, we are now in developing countries and advanced countries, and keep cross the fingers that we have enough resources for more emergency MIS procedures. Thank you very much.
Thank you. Thank all presenters for keeping the time and everything, and we will continue with the others. Thank you very much.
Thank you very much.